something? No? Cool. So many, many more of us live in chronic pain and are continuing to work and to be quiet about it. And I've found in my sort of coaching experience, it doesn't always come up. Somehow people feel ashamed or guilty to bring it into a coaching experience in the context of work. So today the focus here is to really understand pain, understand how it comes up in your coaching conversations, understanding what it means to be in chronic pain, and sort of taking the conversation wherever you would like to go. We have Andrea Powers with us today, and I'm going to introduce her, or rather let herself introduce herself a little bit later, but just thank you for coming. And her co-facilitators, Nicola and Megan, who are going to chime in as well. But in the usual style of these sessions, we're going to go straight off to a breakaway room. And the discussion we'd like you to have is, what do you know about chronic pain? What do you want to talk about? Have you had coaching clients that experience chronic pain? Do you have chronic pain? Or anything else that takes your fancy? I'm just thinking, Andrea Powers, not Peterson. Andrea Powers, do you want to stay in the main room or shall I send you off into a breakaway group?
I don't mind. You can do whatever you will with me.
Yeah, you're going off to some sort of split between America and South Africa. Alrighty, so it's 11 minutes past 4 here. So I'll see you back at 4:35. I know you like to chat. Would that be all right? Okie dokie. Goodbye. See you later.
Physiotherapy, which is called OMT, orthopedic manual therapy. And chronic pain was this separate thing that chronic pain physiotherapists used to do. So if you had someone with chronic pain, you would just send them to the physio who did chronic pain because, you know, you just really, it was really hard and you didn't really have the skills to do it. So that was, say, 10 years ago. But as the years rolled on, you were finding more and more people were walking in the door with this thing. And then there were also nuances as one learned about pain, that it wasn't just, someone asked about chronic and what is chronic. And it's not, chronic pain is not all just one kind of chronicity. There are different kinds of chronic. There's kind of acute pain that you get for long periods of time, or there's the hypersensitivity of pain that you get where your brain has actually upregulated your nervous system. And the point is that it came to a point of going, well, we can't ignore this pain neuroscience stuff anymore. We actually all have to learn it, and then we all have to put it into practice. So that hence there's an academy called TrainPain, which if you're interested in this stuff, the TrainPain Academy is open to anyone to attend, and they have a 6-module course where you it's online now since COVID, and you give a diploma in pain management at the end of it. So talking about upskilling, and those are the kind of things that would be open to you guys. And then realizing that I needed my coach. I really needed more communication skills in working with these patients, because it wasn't just manual skills anymore and exercises, it was actually cognitive skills. Hence, I did the Thoughtsmiths coaching program a few years ago to use those skills to try and help me with these difficult clients. And I say difficult because they usually are complex, and there's usually a long journey involved in them. So that's my background, and I thought I talked about having a particular lens, and the lens that we were taught at university was the biomedical model. And I thought, one of the questions I ask my patients when they walk in the door is, do you know how pain works? What is your understanding of pain? And I thought that it would be a useful way to just summarize that for you, so you have the basic information about how pain works and what our current understanding is of pain, so that you can go into meet anyone who has pain with a bit more information for yourselves. So, share screen. Sorry. Lost this sentence. Yeah. Slideshow, sorry. How's this? Can you see it?
Perfect. Well done.
Okay, so first, just literally starting with the definition of pain, which was redefined in 2020, an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So there's a lot in that. And what's most fascinating is that it's important to note that you can experience pain without actual tissue damage. And what this points to is that pain is 100% produced by the brain. And I think a lot of us still think of it as being pathology-based and tissue-based, but the actual experience of pain is a sensory and emotional experience, and that is all happening up here. If we didn't have a brain, we wouldn't be able to feel pain. And pain is a response to threat, and it's not always, so there's the thing about actual or potential tissue damage. So the potential for harm, that's a threat, it's not actually even happened, can cause pain. So anything that is threatening to the organism can be a mechanism that can cause pain.
I just want to check in. I don't know if it's my screen, but your speaker notes are over the top of your slide.
Oh, sorry. Sorry, how am I going to do this?
I would just move it over. See if you can pull it over.
Let me just stop. I can't. Let's start again. Sorry. Try again.
Yeah, you're fine.
Let me just see if I can move this. Doesn't seem like you can move it. Okay. I'll just have to wing it. One more, sorry. Okay, so that's the definition of pain. So our where we all sit in our, a lot of us sit in our understanding of pain is back in 1664 with René Descartes, who's a French philosopher, and he had this image, or the understanding was that pain was transmitted, not when you put your foot in the fire, the pain message was sent through hollow tubes to the brain and rung a bell at the back of the brain that would create pain. So it's this idea that we were talking about, that linear model, that you have a problem at the peripheries and it ends up causing, it gives you pain. And this is where a lot of our medical intervention is still stuck. So it guides our it guides a lot of what happens in our medical profession today. And so there are three options. If you stick your foot in the fire, you can take your foot away, so you can avoid the pain in modern terms. You can try to dull the sensation down, which would be the modern terms of medicating it, or you could cut it, because it's a wire. So if you just cut it, then it would stop the pain mechanism. And that would perhaps be the analogy for surgery in today's terms. But that we know is not particularly useful. So there are some assumptions that are based in this that are not necessarily accurate. So that we're assuming that there's a direct link between the amount of tissue damage and the level of pain experienced, that all pain is caused by injury and increased pain means more damage, that pain is either physical or psychological, so this mental versus physical. In chronic pain, tissues are not healing and damage is ongoing, that nociception, which is the transmitters of pain, and pain are synonymous, meaning they're the same thing, and this is something we'll look at, and that pain is an input-driven system, so the thing comes from the periphery, and that the nervous system is a wire. So these things are all things that just don't quite make sense within the new knowledge that we have.
Well, she seems to have disappeared, but I found that very interesting, especially the assumption that pain and the cause of was nociception. I don't know how she pronounced that, but those two things were the same. Have I got this right? That it doesn't necessarily need to be a link between how pain is caused and experience. And to me, that makes enormous sense. Mark, did you want to come in there?
Oh, sorry.
No, you didn't want to come in. Okay, cool. Miriam, you want to come in?
Yes. In my group, I was sharing. So my mom, this is about psychological pain, was diagnosed with asthma when she gave birth to my sister. And when we came to the US, it disappeared. Like the x-rays were different. The doctors in the US, when they were in Israel, checked her and the x-rays showed none of the stuff. In the US, nothing. In Israel, it showed her asthma in her body and her breathing and everything. And then we moved to the US and she never had it again until she went back to Israel. And so my entire youth was about being afraid to get my mom going, upset about any tiny thing, because it would create this asthma. So it took many years to understand and study when I was in college about it, but it was so psychosomatic and it was so real, but you can never talk to her about it. And I was always fascinated by that, how that whole thing happened. And I keep thinking that part of the chronic pain is the trauma of it, or the trauma living into and stepping into it.
I find that it's very confusing. And I'd love to hear more directly from Thembega. But that business of why it exists and whether you register it as pain, it's incredibly confusing. And then how your family would have formulated their behavior systems around that. It has so many ripples.
Yes.
Thank you so much for sharing that, Miriam. And I mean, obviously, this is a fascinating case study. I'm longing to dig, but maybe I'll leave it for another day. It's very curious how different countries have, different impacts. Thank you.
Sorry, Julia, can I ask how does like people, I've heard stories of people who've had amputations say that they're still feeling pain from the limb that's not there anymore. Would this sort of also apply into this pain not being just only physical and also being a mental construct?
Yeah, I mean, I don't know how to answer that other than very personally and the confusion around. So I have rheumatoid arthritis, and I never know what's going on or where it comes from or why I should be having it. So it's almost like, or even, like it's cycle. And so I can imagine, pain in a leg that doesn't exist. I think that people understand that to be true. Maybe we'll have Dr. Nicola Graham comment on that.
I mean, it's I find it a fascinating topic because there's such a space for interpretation. While our whole body is mapped in the sensory space in our brain, and is receiving that nociception, it is receiving this. It's not just the receiving and it's not just the mapping, but it's the meaning making of the input that gives it a name. And then the words that we use to describe our experience inform our experience, and they amplify or de-escalate. And there's just so many variables that you can play with.
Yeah, that thing of naming is critical. In the psychological field, some disorders it's better not to name, and some of them you name because they actually create relief. So terminology interferes in the meaning making. Maybe we can hear from you, Thembega. There you are. As Andrea is still connecting in. Maybe.
Okay.
Have you got enough Wi-Fi for your face?
Sorry?
Can we see your face?
I think our computers are set in a way that we don't do videos. I think so. Thanks, Julia. I won't be responding 100% to Mark's question, but I also feel the pain because I did the mastectomy, but there is no breast and I never did a reconstruction, but there is still a pain that is coming up on the breast that is not there, So, and I really cannot explain, and the doctor would say, yeah, there will be some pain and it won't go away. So there will be that pain, although there is not that leg or there is no breast, Yeah, you will feel that pain. And I'm experiencing that. Thanks.
Thank you very much for sharing that, Thembega. It's a really interesting thing and makes one wonder if pain is like somehow in our aura. And then, how do you work with that in coaching where someone doesn't have a leg or a breast but still experiences these parts of themselves? How important it would be to acknowledge that.
I'm sorry, Julia. I think Alistair at some point said that he made a comment saying trauma, you know, the body keeps score. Can he elaborate on that and what his thinking is around that?
Sorry, my goodness. I thought my computer was plugged in and it was disconnected at the this wire came undone. So I was sitting there happily thinking it was plugged in and it was dying. So sorry.
You're amongst fellow humans. We make errors regularly on this show. We just going to, Mark asked Alistair a question. I'd love to hear his answer and then we come back to you if that's okay. Cool.
Well, it's not my thinking. Forgot his name. I think his name is Basil van der Kolk, who says that when a trauma event happens, the brain might just process it so quickly that it stays in your body. Then you think, oh, life is okay, and you change countries, etc. And then a triggering event happens, and it comes out of wherever it was staying in your body, maybe years later. So, so in my case, I've got a condition that the medical field has diagnosed as fibromyalgia. And in my view, they diagnosed me because they couldn't find anything. So I went to the best doctors, the best in Cape Town, the Springboks doctors, etc. X-rays, MRIs, they found nothing, but I still have this lower back pain, which goes down to my knee and my ankle. So I've tried alternative treatments, and I've been told that it's in my brain, that my brain is telling my body, so that there's no tissue damage. All the MRIs from my lower back to my ankle came out negative. Some of them were done twice. So some of these doctors were saying that it's all in my head, and then because something happened that triggered me, that triggered that pain that was hiding in the body somewhere. So the pain is still there, but I take meds every day because I couldn't sleep. So I had to take, I take Schedule 5 drugs to manage the pain. But the pain is still there every day, but at least I get to sleep, because it was affecting my concentration at work and also being a thinking type. I couldn't make decisions because I couldn't sleep. So I'm quite aligned to Andrea Powers' slides about pain not necessarily being caused by tissue damage. I think there is that aspect of it just being a mental thing that needs to be processed by someone for the pain to go away. But for now, I'll stick to the meds.
Thanks, Alistair.
Thanks, Alistair. So if we carry on, we'll now get a better understanding of why you might be feeling what you're feeling. Can I go back to the?
Yes, you go ahead. Yeah.
Where is it? Sorry. Keep losing my. Where's my Zoom gone? Sorry. Yeah. Okay, so we were on that. Okay, so we're on the old view, and now this is the story about tissue damage. So in the two pictures, this is a story of two nails. It's a true story. The one was a construction worker who shot a nail gun through his foot and had to be taken to ER and sedated for the pain, for them to cut his boot off, only to find that the nail had gone between the two toes. So in the scenario one, there was absolutely no tissue damage, but the brain completely freaked out, produced a huge amount of pain, so much that he had to have intravenous sedation And so the whole story was pain does not equal to tissue damage. In the second scenario, construction worker accidentally shot himself in the head with a nail gun and didn't notice, which is hard to believe, but anyway, true story apparently. 6 days later, he went to the dentist because he had a toothache, and when they did x-rays, they found that he had a nail in his through his jaw. And so basically these two scenarios are very helpful indicators for us to realize that pain is not equal to tissue damage. And this is a construct that it takes a long time to break down unless you've been in the scenario like Alistair was saying, where he has the proof of the MRIs to say there's nothing wrong, but he still has this pain. It's very hard to believe. So the question is why? So now we have a better understanding of how does pain actually work. We have 400 nerves in our body, which equates to about 70 kilometers of nerves placed back to back. They are all connected like a road system, and they all connect to our spinal cord and then into our brain. And the way that they work is that they have a resting threshold of electricity, and and they have a firing threshold. So you have a normal amount of sort of buzz going through your nerves all the time. If you stand on a rusty nail, the alarm system is going to activate. It sends a message to the brain to tell the brain that there is a problem, and then the brain will do something about it. Rather than what we originally thought was that we are sent a pain message, we are just sent a danger signal. That's all that it is. The nerves send danger signals, and then the brain gets to decide what to do. But mostly after you've had your tetanus and you've fixed your foot, you will end up, those nerves will go back down to the resting level, and you'll just carry on as normal. So that's the normal scenario for acute pain. But what sometimes happens, and this happens, someone asked how prevalent is this? It can be as common as 1 in 4 people, that the nerves don't go back down to their normal resting level. So the threshold, the nerves fire off to the brain, and the brain gets a message that there's danger, and you sort the thing out. But then for some reason, the nerves don't go back down to their resting level, and they end up sitting at this heightened level just underneath the firing threshold. So what that means is that whereas before you had lots of room for activities, you could sit for 3 hours without back pain. Now, since you had your episode of back pain, you sit for 5 minutes and you get back pain. And this can be an explanation for why there could be pain without tissue damage. So this is not the tissues that are damaged. This is just the nerves in the area of the damage that are hypersensitive. They have an a decreased threshold, so they fire off much more quickly to the brain to tell the brain that there's danger. So the question is, why does this happen? And people say, well, why did the other guy who had back pain get better, and why didn't I get better? And there are lots of reasons, and this is where the coaching stuff comes in. There's this complexity of brain stuff going on that is part of the processing. And some of these are failed treatments. So for instance, if you have had numerous treatments and they keep failing, your brain's going to retain its defense mechanism, because it's like, well, this is clearly not working, so we've got to keep our body on high alert. Different explanations. So you go to this doctor, you go to that chiro, you go to that physio, and they all tell you different things, and your brain's completely freaked out, and it's like, well, that person says it's that, and this person says that, and I actually don't believe any of them, so I'll just keep the alert going. And then just being in pain can be a threat to the body. So you know how unpleasant it is to be in pain. So if you are in pain all the time, your brain is going to continue to be on high alert. So there's no reason for it to decrease the alert level. And then there's psychosocial issues, the fear and anxiety, your family concerns, your job issues, your financial strains, all those things play into it. So whatever's going on up here can influence what happens in terms of your pain. Another way of thinking of it, how your body responds, is if a lion were to walk into the room right now, your body would go into fight and flight, and you would take action. You would hopefully escape. And once the lion had disappeared, you could go back down to rest and relax, and your parasympathetic nervous system could kick in. But what sometimes happens is that that lion does not go away. So Alistair, you were asking, and Mark was also talking about the stress that happens in the job. So it's not always a one incident. Sometimes it is a one incident trauma, but other times that lion just follows you around all the time. So we end up in this low, constant state of fight or flight, where you are, you have a domineering boss. You can't not go to work, and you have this boss who's constantly abusing you. So that's a state of stress that it could be maintaining your brain's threat level. You're going through a divorce. You have financial problems. You sit and work long hours and you can't go and exercise. You don't like your job. All these things play into this heightened state of alert that your brain will remain in. And your brain is responsible, remember we talked about at the beginning, for producing pain. So if your brain is under stress, then your pain is going to be more inevitable. So this is our current understanding of pain. Instead of that linear model, we know that the tissues can give us input and the environment can give us input. For instance, if you sprain your ankle running across the road, your brain is going to assess whether you're going to get run over or whether you're going to survive. So survival is much more important than pain. So if there's a bus bearing down on you, you're not going to experience any pain, even if you've torn the ligaments in your ankle. So the environment in which incidences happen, or pain incidents, can be really, really important. Sends messages to the spinal cord, sends messages to the brain. The brain goes through processing our experiences, our past memories, our beliefs, whether our father had back pain. We have a family history of arthritis. Our grandmother ended up in a wheelchair after her failed knee replacements. There's a lot that's just stored up there that we are so not aware of, that can influence what we then experience. Our cultural beliefs, we talked about generational, and Meg brought that up, how people experience pain differently, generational Enneagram. So our personality is going to be very, very important in how we experience pain. Some people just want to get on with it and push through and ignore their pain. And that can also play into the chronic cycle. The type 1s who they can't have this pain. They just need to get on with it and just need to fix it. But that's not necessarily how it's going to work, because they're not prepared to go through the process of looking at all the things that affect it. And so pain is an output. Pain is not an input. It's all the things happening, processing, and then pain is an output. And if we can understand this model, we have a much better understanding of what lies behind all everyone who you might meet in your coaching sessions who may be in pain. Someone talked about this came up for me. It was I think it was Alistair talking about whoever it was talking about alternative methods of looking at things, because what happens is when we have persistent pain, we get less active, we end up being loss of fitness, we get weak muscles, joint stiffness, we can't sit for as long as we used to be able to sit, we don't exercise, we create these no-go lists of things you can't do, we avoid things. Oh, it was the sleep thing that triggered that thought, Alistair, where you're saying you can't sleep. Sleep is an incredibly important thing for all of us, and if you're in that much pain, then you're certainly going to try to medicate it, because pain affects your sleep. You then are tired, you have fatigue, that increases your stress, your fear, anxiety, anger, frustration. Then you've got your medication side effects, which Nicola was talking about, where you actually may be getting side effects from those kind of things. So in this work scenario, it comes up that we talk about the brain being in a pain meeting. So when you have pain, all sorts of areas of your brain are recruited to deal with the pain, areas that should be dealing with other things. So you're sitting with someone in a workspace who's in chronic pain, and they're talking about the fact that they can't focus, the fact that their memory isn't good anymore, the fact that they lack motivation, and the fact that they're tired. So all these things around work and what they need to be at work are real things. This is not in their head, it's in their brain, but it really is happening. Weight loss, weight gain, negative thinking, fear of the future, and then this is where a lot of the coaching stuff can come in, where you end up the worries, the concerns, or the extra things, the relationship concerns, and then the cycles round and round. So the physiotherapy management of this is to take your brain that is in high alert and to give knowledge. So what I'm giving you here in a little 10-minute chat is what we do with our patients. We teach them, and this is what can be helpful in your coaching scenario, if you have the knowledge, is to teach them about how pain works. And when they do, the brain is less threatened. So they have done studies on this to find that when you provide knowledge or you impart knowledge, you go, oh, thank goodness. So now I know why I'm in pain. I understand why I have no tissue pathology, but it is absolutely possible for me to be in extreme pain because I have a heightened nervous system. I've got a sensitive nervous system. Aerobic exercise, relaxation, meditation, mindfulness, diaphragmatic breathing, pacing exercises. We slowly introduce people back to their workspace. Manual therapy, we've talked about chiro, we've talked about acupuncture, all those alternative and normal kinds of therapy can work. And then goal setting, which is your guys' real, you're really good at that. It's really fundamental in helping people to move through the state. So that's the physiotherapy management. And this slide just helps to summarize what needs to happen from a self-care cycle, which I thought incorporated a little bit more what you would probably be dealing with from a coaching aspect. Activity planning, well, first thing one is acceptance and really trying to find improved pain relief. So either getting the right medication or doing exercise or whatever it is that helps to get your pain levels down a little bit. Then working with activity planning, goal setting, self-help options. All these things are kind of part and parcel of a lot of the work that you do, getting planning, prioritizing, pacing activities, healthy eating, relaxation, ways to improve sleep, skills to manage unhelpful moods, challenging your negative thoughts, your positive self-talk, sustaining your change, managing your setbacks, and then assertiveness and problem solving. So that in a nutshell is our current concept of pain and chronic pain and how to manage it. And so in summary, that our health, our mental health, our physical health, it cannot be separated. We've got what's happening biologically, what's happening psychologically, and what's happening socially is all integrated into that one person. And what the chaplain was saying about how your spiritual, what's going on spiritually can cause physical pain. It's just all intricately linked. And unfortunately, the medical profession haven't quite, it hasn't been widespread enough in this dissemination of knowledge. So hopefully for those of you out there who have not found a solution to your chronic pain, know that there are quite a lot of therapists who work around these, along these lines, and who are, really working successfully with moving people back into a normal life and functional life. One of the things we do say though is that we work for function, not for decrease in pain. So the pain will slowly go away, but our aim is not to take the pain away. Our aim is to return back to our normal activities that we might have retracted from because of the dysfunction, and do things despite pain. And as we do that, pain slowly improves as we start to integrate ourselves back into our normal life. Yep, that's it.
Thank you. Thank you, Andrea. I know there's a lot of conversation and questions around what you've said. Maybe we could just open it up to the floor And I see Mike has got something interesting already to talk about. Maybe that's a good place to start. Micah, do you want to go ahead? Thank you so much, Andrea.
Thank you. Look, just listening to this whole input, by the time you're sitting in a coaching environment and, the person sitting in front of you is experiencing pain. In the background, it could have a physiological cause, in which case the remedy would be physiological. But it sounds like the overwhelming majority of what is presented actually has another cause. And the question then becomes two things. First of all, within the coaching context, would that be appropriate to actually start dealing with that? Because, one person may present as physical pain, another person may present as emotional pain in its various forms. It's pain that brings us to growth. And that then being the starting point. And the other thing that we've discussed in the small group is the whole issue of vulnerability. Because we're uncomfortable discussing our physical pain, but at the same time, especially where you in some kind of personal growth context, the expectation is that everybody comes to that session willing to work through the personal issues that cause them pain, psychological pain or otherwise, and holds them back. And that requires an extent of vulnerability. And it strikes me as odd that people will discuss issues that cause them psychological pain, but yet they would be very hesitant to discuss physical pain. And why that should be so, because ultimately we're all flawed human beings, physically and mentally and psychologically. And it then goes back to something else, which is where we, often you want to present as capable. It's an ego defense, but it's also in a context of human beings being viewed as utilities. So your productive ability, it's a very utilitarian view of what is human. The value of a life tends to be what it can produce. That's the current narrative. But we know that narrative is false. Why do we encourage it?
Micah, thank you for challenging us. So much in that. I don't know if there's anything that you want to respond to, Andrea.
So we said, if someone presents with pain, where is it your role to start investigating whether there's the psychosocial components or is there a physiological cause? And I think the thing you need to probe is, have they had that physiological cause checked out? So the people that we're talking about are the Alistairs who've had double MRIs of his back. He knows that there's nothing wrong. He's had the blood tests, he's had the bone scans, or whatever, where you've ticked all the medical boxes, and you've been to physio and you've tried physio. But even so, anyone in any kind of pain, even if it's pain that is physiological, there always are aspects. I have now started talking to just my acute pain patients who've got an episode of lower back pain, just explaining to them how the pain works so that they understand that whatever's going on in their life can make their pain worse. It might not be chronic pain. You can have the shoulder injury that that you're going through a divorce, and that shoulder pain is way worse for those 3 weeks where you're under the lawyers, under the divorce proceedings, and then the shoulder pain resolves eventually after you do your strengthening exercises, and it's not chronic pain, but the psychosocial factors that were influencing it right then were making that pain worse. So that's something to just you can always investigate the psychosocial factors. I think that's what I'm kind of getting at, even if there is a physiological cause. So your role as coach is always going to be helpful to investigate the what's going on for them, because it will give them insight into maybe why they're feeling worse.
I think this is a very interesting conversation, and some really good skills could be helpful around pulling out the narrative that they tell themselves about the pain, and how they explain it. So in a way that responds to Miriam's question, you know, because you allow them to boundary where the boundary works for them. But for me, like the stories that people have around pain and how to work with pain and whether they deserve it or whether they should even reduce the pain or why they don't take pain, you know, anti-inflams or whatever. That for me is a fascinating opening into whatever is emerging to be grown through in that particular moment, even if it only has a physiological base, although I somehow struggle to believe anything only has a physiological base, but that's because I'm a bit woo-woo, perhaps. You know what is also interesting, if I can just carry on, is spiritual ailments. And, you know, when you pull a narrative out or you help a narrative to emerge, then you can find these spiritual narratives, which might include like phases of life or passages or initiations or cleaning out. Yeah, and it would be very interesting to hear what the chaplain had to say about that.
Yeah. Can I say something about that, that narrative? It's such an important aspect of investigating what it is that triggers the maintained response of the brain. So it's not like the brain just remains in high alert all the time. It's when you experience the pain, what is the narrative? What is the belief? What is the underlying story that you're telling yourself? Oh, my knee tissue is damaged. Or can you change the narrative? And can you change the narrative to saying, this is a sensitive nervous system? And what is it? What were the triggers? There's another tool which we call the protectometer, where we look at all the aspects of positive and negative influences in your into your pain experience. And we call them DIMS and SIMS, dangers in me and safeties in me. And getting people to understand that you could have work could be a sim and a dim. So there might be some nice things at work that make you feel good. And then there might be some dangerous things at work that you really don't like. So your pain could be triggered by the dims, and you need to work through the sims to try to kind of work through those things.
Sounds useful. Brian, was that you going, or was that Alice? No, you're not on.
I think it was me, Julia.
Hello, Bruce. It was a
Hey,
male.
I wanted to go back to Mikey just for a second before I lose the thread. I think, Mikey, that part of it is that we think about, you know, ourselves as coaches, or Andrea thinks about herself as a pain specialist, and we don't think in terms of the severe training, cultural training that Western and Westernized, you know, European medicine has brought. I would never go to a coach to talk about pain. I'd go to Andrea. I would go to you, Mikey, to talk about a divorce. And there's the marketing around what coaches do and what the medical profession does is still so ancient that I think part of it involves, what does it say on your website about what you do, Mike? And does it include a more holistic approach? We've never met, so I don't know, but, or does it follow kind of traditional coaching lines? So I think some of it is on us to advertise about what we do in a way that makes people willing to come and integrate their lives with us rather than separate their lives with us.
Beautiful.
If I may, you know, it's just in touching that last point, Bruce, if I may. So no, I'm not a coach. I happen to be a rather bland financial services practitioner.
Oh, I need
economist.
you. I need you so bad.
But I can sure help you get everything in a divorce. So I specialize. But the point that I was wanting to make is that logically it doesn't make sense
Yeah.
You know, we are unitary beings. We have different facets, but we are one thing. And that one thing is an interaction between a bit of wet matter, the meat sack, as it were, and our consciousness. And to treat it as separate things, it doesn't make sense at all. So the first question that I would ask if I were the doctor of Alistair is to say that, okay, well, we've tested your meat sack, as it were. We find no obvious issues there. So the next question then has to be, but what burden are you carrying that is so heavy that it's actually breaking your back? And can we go there? You know, because you're just not separate things.
Mm-hmm. Yeah.
So it's the simple logic.
Yeah.
Do you want to comment on that, Bruce?
No, it's what I was trying to say, but much more eloquently. She said it much more eloquently.
Well, if I can just say so, from the outside, I do think there's a bit of two peas in a pod going on here. And Micah is far from a bland financial advisor. We'll tell you later what she does. I love Mark's question in the chat box. Mark?
Hi, Julia. Yes, I was just wondering, and I wanted to ask Andrea. I know she mentioned it briefly in our breakout room, that when you're coaching someone, how do you determine that something that they're struggling with, be it a lack of motivation or will to do something, is actually genuine or could actually be some sort of pain avoidance, and how do you help them through that?
It's a very good question. Because, and it relates to what Miriam said, is what if a client is unwilling to go there? So I'm seeing a 15-year-old at the moment who's been off school for 6 months, and he's got chronic pain. He's got pain in his knees and his ankles. And there is the story that there is pain. So not going to school is a pain avoidance. And then there is the other, which is that he just hasn't been able to motivate himself. So I don't think the two, they're often not separate in someone who is who's been in pain for a long time. There is genuine pain, which leads to avoidance. But sometimes that is, you see the clients who quickly move through and return to school and return to work, and they are motivated and they have that self-motivation. And then you see the clients who are, there's something that's stopping them, and it is not related to the pain. It's something, I mean, it is related to the pain, but it is a separate thing. It's actually, and it might be caught up in a belief system. So it came out months down the line that he believed someone else was going to make him better. He kept coming to me every week thinking that I was going to make him better, until eventually I posed the question, who is going to make you better? And he came out with, well, you are. And I was like, well, no, it's you actually. And so this learning click had to like click in that he was responsible for it. So that was what was holding him back. And he was just sitting there looking like he had lack of, and there's other things psychologically that would play into that lack of motivation as well. So it's not always pain. Something about school, not liking that environment, whatever it is. So I definitely think the two can be separate, but they also occur together. I don't know if that makes sense.
Yeah.
It's hard to separate them, but they can be not because of the pain.
I love the research into motivation, and just speaking from my own kind of disease orientation, it's incredibly hard to take responsibility for your own disease. You just don't want to. Why should I? The rest of the world doesn't have to. Why do I have to do this? And that's an area that we can help with as coaches, is the anger and the absolute outrage. I have to give up drinking wine? No. Why should I? And I think that's where coaches can be helpful. in that acceptance piece. And I saw something quite interesting, that people who accept their disorder and move towards taking responsibility for it have the best outcomes. I mean, it's a no-brainer, but yeah.
Yeah, that's absolutely it. And what really strikes me is that the types of help for chronic pain are quite hard things to do for anyone who's not in pain, right? So we're asking people to meditate, to be mindful, and to exercise, to eat healthily. Like, how many of us struggle with those things? We know we should do them, and we're not in pain, but the motivation to do those things, those behavioral things. So it's a bit of an unfortunate thing that the toolkit for this thing that's really, really incredibly hard to deal with is quite tough. It's a tough ask. And so we really are sitting with having to acknowledge that it is really hard to do this thing. And that's why you need to try and kind of hold their hand through it and go, right, you know, and that's where the coaching would be really helpful, is that whole, what are your goals for the next week, and where are we going? Because to stick to the program, to stick to consistency in the thing is the most important thing. And when you drop off your consistency in whatever it is, often then you have a resurgence.
Yeah, I just want to say something there, because I'm of a rebellious personality. But Andrea, I sometimes find if I break all the rules together in one big go, the pleasure and joy of that event sometimes makes up for the week of pain.
Worth it.
Personality. I can see Alice might be the same. Yeah. Does anyone else have any other question? Nicola?
There was research a little while ago around people who get chronic pain and joint replacements. And there was so much about whether you saw your new joint as foreign or whether you saw your new joint as you. And the kind of outcomes of people who spoke about their joint pain as this thing, I mean, their new joint, their replacement joint is this thing. Were much worse than people who spoke about me and integrated it as part of their new identity. And it's just, I mean, it's quite an interesting thing. I haven't spent a lot of time thinking about, but whether we experience our illness or disease or pain as something other than us, or whether it's integrated as part of our own identity in a healthy way, whether that has an implication on how we experience it.
I think, Nicola, I think you are, what's interesting to me about that is your conversation about breaking all the rules, Julia, and your conversation, Andrea, about motivation. That I think that all of those things, the common thread between those three conversations is how come you're in the world? What's the deeper why? That motivation only works if your psyche has answered the question, why does this matter to me? You don't stop smoking because you want to live longer. You stop smoking because there's a reason to be alive. It's not just the life. And so I think that's what the medical profession and the coaching profession aren't very good at, really. We're good at motivating people on kind of a surface level, but not helping people answer the deeper question of, why are you in the world? Which is a multicultural question that all cultures had a way of answering, but it's really lost in the therapy and coaching world for the most part, because we don't really have tools to do that. We're getting so science-based that it's, a strengths assessment ain't going to get you there, no matter how powerful it is.
Bruce is coming to chat to us about purpose. So he's given you a sneak preview and we'll send you dates. He's incredibly interesting. It is an incredibly powerful and life-affirming process. I went through it last Friday night. So come and hear Bruce talk about it. I just wanted to consolidate?
That made me think of what we talked about in our little group, Bruce, about the gift, and how what you were saying, that very often people come to their gift through a traumatic experience. You said almost always, and you talking about pain as a thing that happens that changes you, and can we look at the positives? Can we extrapolate, because it's often a negative experience, can we extrapolate the positive things that have come out of this incredibly horrible thing that has happened? And I mentioned this little clip by Tamar Pincus, who is a psychologist, and she describes how chronic pain, she uses red plasticine and blue plasticine, and how when you start off as the red U, and then you add the blue back pain and the blue neck pain, and then the blue not being able to work and not being able to exercise, and slowly you want to pick out those bits of blue and take them away, but you can't, because the plasticine gets stuck together. And so then the blue integrates into the red, and you become a different person. So this chronic pain that has led to all these life experiences, whether it's stress in the relationship or not being able to work, not being able to exercise, you become purple in the end. So you are no longer the red you that you were before. And it relates to Bruce's work about what gift comes out of that. Who's the red you from before, and what's the purple you, the blue integrated into the red? What can you bring to life that you will still celebrate life, even though you've had this very traumatic thing happen to you that may have changed your life forever?
Hugely powerful.
Can I add something? Which is just a kind of a vignette of exactly what you are both talking about, Bruce and Andrea, that I've experienced in a coaching relationship recently, which was just so beautiful. So I have been coaching a woman. She's an Enia 8. She goes at life full steam. And then she had an accident and ended up in hospital having a knee replacement. And it was very, very traumatic for her. And she was out of work for a good few months, and she was in huge pain and had to keep going back, and her legs swelled up and things didn't go as planned. Anyway, it was a horrible experience for her. Fast forward down the line, and the way that she has re-authored that experience has been so beautiful, Bruce. Just what you were saying was making me think of that. She says, I appreciate being able to put my shoes on now. She said, the first time I had a shower, it was like after this, like she'd been in bed having bed washes and stuff for ages. She said, it was like the first time I've ever had a shower in my life. It was such a wonderful reauthoring, like a different narrative that she was telling herself about how this painful experience had brought all these little joys that she had totally taken for granted into the foreground of her experience as wonderful. Yeah, I mean, there's so many examples that she listed at the time, but it was just such a lovely thing. And maybe that is one of the places where we can play, is this like reauthoring of the story. Yeah, it was just, I mean, she was amazing. So, yeah.
That's lovely. That's a great contribution we can make. Is there anything burning, or can I introduce another idea?
I'm still sorry if I may, Julia. I'm still stuck on something here. And that's the whole narrative and the whole contextual thing. So if you first experience physical pain before it becomes chronic, and this is the subtext that I'm starting to pick up. So an issue presents, whether psychological or physical or whatever, and it now manifests as physical pain, and it's very socially acceptable to then go and say, give me a day, I need to go and see a doctor, I think my body is broken. And that's okay as long as the body doesn't stay broken. Okay. The moment it becomes chronic, then it becomes less okay. This is the subtext that I'm picking up. And it's not okay to say, well, actually, I think my mind is broken. Can I go and sit under the tree and just figure myself out? That's also not acceptable for some other reason in our cultures as it predominates. So what we're sitting with here seems to be almost an epidemic of people presenting physical pain that may have a physiological basis. But even as Nicola has explained in terms of when people, receive replacements, if it was my body that was broken, of course, I'm going to see that knee as something new. But if it is actually my soul that's broken, and as a result of that, my body is followed suit, then I'm going to look very differently at that knee replacement. Now, in a coaching context, you can't deal with a kind of deep therapy that something like that would require. But in surfacing it, often it gives you a signpost. And often it's appropriate to then say, well, consider these possibilities. We're not saying it is so, but consider these possibilities. And you may want to follow up in a separate session or, through a separate route to actually start exploring these things. Because it is starting to impact your physical body. And similarly, your quality of life. And it's almost as if the body or the self is saying to you, well, okay, I can't get your attention if I present psychological symptoms because you've got a great capacity for self-delusion and rationalization and all of the other things. So I'm going to break your back now because this is an issue that just has to be heard. And then also in terms of dealing with that and making the lifestyle changes, the coaching around that, and the coping mechanism. And this goes back to the concept of value. And also what Bruce has raised, it's that thing of, you wouldn't allow a child in your care to do some of the things that you will want to do to yourself. Or anybody in your care for that matter, but you are in your own self's care, and it's just, it's how we value ourselves, whether we worth that kind of effort, that kind of commitment, that kind of care. And it goes back to the reason to be alive. It's just a very, very interesting subtext that I'm picking up here.
Sure. So many things, such big things. Such very big things. Just as one last thing, and kind of leading on from Micah, was Micah talking about, if your soul is broken. One of the things that we're seeing at the moment is a lot of broken souls. And I'm talking a lot. We do a lot of assessments on maturity levels. And we're seeing massive amounts of fallback. And people that were assessed before have come back, and reasonably significant numbers. And I think there's something here about something that went on with COVID, that maybe people don't want to have broken souls anymore, or their bodies are broken, or there are more people in pain. Something very weird is definitely happening in the world. Then I think of this guy called David Smale, who says, he's a very amazing psychological researcher. He says everything is contextual. Nothing is intrapsychic. It all comes from outside. And all this blaming of the individual because they haven't, remedied their life because they still smoke when they live next to a, a polluted thing. And maybe that links up with what you were saying, Micah, is it's a kind of a neoliberal focus to locate the pain in the individual rather than in the society. And maybe that's how people internalize that. I don't know, just an idea. and you get very sensitive people and people with, I just find it so interesting that in the coaching community, for example, there's so many people that live with chronic pain, and they live with the severe stuff, and they also live with the autoimmune people.
I wanted to make a comment about the community. In the physiotherapy community, there is a high correlation. The work that we do, we should have a high instance of lower back pain, chronic debilitating lower back pain. We work bending over people, we're lifting and all, but physiotherapists have a very low level of back pain. And there's somewhere in there this realization that the threat level for physiotherapies of back pain is very minimal, because we deal with it all the time. We know people get better, and so we don't upplay it. So this thing about in this community, how different things show up. So in coaching, people living with chronic pain, it's an interesting concept around how and what is going on for them to do with their profession and the way they are, as there is physiotherapists downplaying another kind of pain because in their profession that's kind of normalized.
Maybe that's what we're up to as coaches.
Lots going on.
Mental pain. That's fascinating. We've got one more minute, and maybe we should use it just to say, Andrea, thank you. You've really opened up our minds and educated us around pain, things that we kind of should have known. Thank you so much for that, and the systemic nature, and really some useful stuff that we can use in conversation with our clients. So thank you so very much for that. And then to the
sorry about the screen. Sorry about losing it, and also I realized in my screen share it was half the pictures. People were on it, inexperienced.
You were wonderful and incredibly helpful. Thank you. And then to the group who's really been very open about sharing, and I just think some incredibly useful ideas came out of this. Not the least of which is our role in helping people find purpose and meaning in life as a way to make sense of and deal with pain. So Bruce is actually on at the next session, if you'd like to come and join us and hear him talk about core gifts. And I see, Mark, you're already excited. Cool. So thank you so much, everyone. Have a beautiful day, stroke evening, and thank you for coming.
Thank you.
Thank you.
Yeah.
Thank you so much. Bye-bye.
Cheers, guys. Thank you so much.
Bye.
Bye.
Hey, Julia, will you stay on for just a second?
Yes, I will do. Absolutely. Absolutely. And Andrea, thank you. Don't feel bad about that. We all do it at some point in our lives. Really. It was brilliant.
I wish one of you had said just what you call it, we minimize they were all, I didn't realize that everyone's faces were half over the screen as well.
They weren't. They weren't.
They weren't.
No. Oh, were they not? Okay.
No, they weren't.
I could see everyone.